Hey everybody, welcome to another episode of the Med List. And Donna, I tell you what, it feels like it's been a while, right? I mean, are you just like jumping back on the bike with me? Did you take the training wheels off today?
Absolutely. I don't even know why it feels like it's been a couple of weeks, but for some reason it does. And
Yeah.
I guess a lot has happened during that time. We finally got to see each other and meet in person. So how great was that?
I
And I
got
was worried you were AI.
I know she did prove out that I am not AI, and I got to give Donna, the wonderful Donna Bartlett, a big hug, and we got
Yeah,
to see each other for a second. And
yeah.
then between my missed flights and Donna's fantastic vacation that she got to do, we only got to see each other for a moment. So it wasn't enough time, but we're really thankful that we got to be together for a little bit, and hope you guys, especially during the holiday season, get to be in person with a lot of your loved ones. It's so wonderful to kind of be there. Update, I guess, for the audience, Donna, on the stuff that you and I have been doing. Let's hear from you. What have you been up to lately? What are all the exciting things?
Yeah, so there's so much going on around age friendly, and so I've been setting up some programs and working with my hospital site, and I hope to be instituting some deprescribing champions, if you will, age friendly champions right at the hospital. So getting a team of us together.
Oh, that's so huge. No, I love it. I did a trip. Don and I made it to ASCP, the American Society of Consulting Pharmacy location. Don and I both spoke when we were there on various subjects and got to meet with a lot of colleagues that are doing work, primarily in the senior care kind of setting and world, but really expanding to all consultant pharmacy. And so that was neat to see. What was it again, Donna? Riding the wave of change. So, really seeing what healthcare is changing pretty rapidly. You guys know this if you watch the show often, that we talk about that all the time on how some of the changes are good. Some of the changes are even more emphasis for patient advocacy. And so I'm really excited to see the things happening inside of that particular niche, within the healthcare system. Another trip that I took was with the crew from Percipio Health, really looking into artificial intelligence and biomarkers and how we're trying to leverage those inside of systems, especially when it comes to medications and some signals that are going in through there. And it was great. I mean, it's really neat to be able to see folks trying to connect all the dots and trying to make them meaningful when it comes to empowering patients and empowering clinicians to be able to make those direct connections. I read something this morning, Donna, that I think is a really good one. We'll have to bring it up with our guest here as well. But it was basically this. It was saying that the worry is you've got the clinical side of the matter of saying, okay, I'm a clinician. I'm going to use this AI scribe to listen to my patient and then be able to feed me the details back that would be the most important. Okay, great. Then on the patient side, I'm going to use artificial intelligence to make me smarter for my visits, to be able to see the clinician, ask the right questions. And then what happens? AI and AI talk to each other, and there's two humans that miss the boat, right, on all the other connective kind of components. And so I think that's another important piece of having that face-to-face interaction and having a relationship with those that you're trying to connect with. And sometimes that's difficult because of time, allowances within healthcare. And another thing that makes it somewhat difficult is sometimes expense. Like, we just can't afford to be there and do the things. And so I'm very thankful for our sponsor and Remedy Chain to allow for one of those expenses of medications to be taken care of by some groups out there like Remedy Chain that really care and want to make sure that you can get those medications that you need.
At Remedy Chain, we know throwing away perfectly good medicine feels doubly wasteful. It's bad for the environment, and it could have been used to help a fellow human in need. So we found a remedy. Now you can donate your unused meds. Our pharmacists inspect and certify every donation so it can be safely and legally redistributed to vulnerable patients. Visit donatemymeds.org and click the Donate Meds button. Unopened, unexpired medication in original packaging is eligible for donation. Open bottles, controlled substances, and temperature-controlled meds are not eligible for donation. Once confirmed, we'll send a donation form to sign and prepaid shipping instructions. And we'll let you know once we've matched your donation with a patient in need. Together, we complete the chain. Remedy Chain. Visit donatemymeds.org today.
Awesome. Okay, so something else, Don, I had to bring to you, and I'm sure you've experienced it, especially being on a few flights of late as well. sitting next to another human being, right? If you're willing to pull out the AirPods, if you're willing to kind of engage in conversation, and maybe I just forcefully kind of pull them in. And I know that my family would definitely say that, Kevin, that's something that you do. But try to bring them into real conversation, about things that matter to them. And you end up finding out that sometimes people need an ear. Like they need someone to listen to what's happening in their lives and kind of what's going on and how it's working out. And so, bringing on our next guest here, I think that something that we're seeing through some of these services that are exterior and really pointing inward, like what Brian and his team are doing of building relationships and making connections for folks that feel isolated. It even goes beyond the care directly being offered, and it's creating some relationships that I think long term can be very, very meaningful. So excited knowing kind of Brian's heart and his background and connection to his community. Really looking forward to having him talk to us about what they're trying to do on their team and with their company. So I'm going to add him to the stage now.
That's great. So,
hey Kevin, hey Donna.
So nice to have you with us today, and I want to share who you are and a little bit about you, Brian. So today we have Dr. Brian Freeman. He is a foot and ankle surgeon and podiatrist who maintains an active clinical practice in Richland, Washington. He has 12 years experience since completing his foot and ankle surgical residency at the Cleveland Clinic Foundation. Dr. Freeman spent over a decade applying his expertise before channeling it into health, technology, entrepreneurship, which he pursues alongside his surgical work. He is a dedicated father of 7. He and his family actually took time to live in Argentina for a year. He immersed his family to allow his children to experience life as a minority in a foreign country and to learn a new language. And he's just driven by compassion for vulnerable populations, particularly elderly individuals who lack access to essential foot care. And Dr. Freeman fundamentally believes that living with terrible looking and feeling feet decreases human dignity. And I'm going to stop there, Brian, because I want you to share some more about you. But thank you so much. And just even in our backstage before the show, I'm already learning so much from you. So I'm so excited to share what you do and knowledge about the importance of feet and foot health with our audience. So I'd love to hear more of your journey and kind of the role that you're taking from maybe your typical, day-to-day, what every other podiatrist might be doing to what you in your journey has taken you.
Thank you, Donna. So I go back when I as a foot and ankle surgeon, as most podiatrists take that road and they work for the rest of their lives, 4 to 5 days a week, taking care of foot health and everything. And I remember one specific instance where a patient came into my office and she had her toenails were actually clicking together. They were so long, so overgrown. Sorry, hopefully nobody just recently ate or anything, but I walked in there and I was like, what have you been doing for the past year? Because they had been growing for at least a year without care. And she's like, I haven't been able to wear shoes. I've just been wearing slippers. But she got somebody to come bring her into the office. And we took care of her toenails for her. But as a resident in a hospital and everything, we weren't trained to do that. We were trained to be surgeons. And so, but whenever anybody came in, I felt so much compassion for them that I always took care of their toenails. And then I said, okay, you can get connected with this other podiatrist in the community that does foot care, trimming toenails and calluses, or you can see this foot care nurse. But as I started to do that, then the podiatrist said, you know what, I don't want any more of these referrals. I'm busy. And then the nurse, sometimes that would work great with a foot care nurse. But then other times she was like, oh, I have tendonitis, or this nurse left town and we need to find somebody else. And I just felt like, man, there's got to be a better way to connect the dots, because if I'm having difficulty finding care for our vulnerable adults, then as a foot and ankle specialist, for sure, the primary care providers, the family members that don't know where to take their loved ones are having that difficulty as well. And so I set out to try to solve that problem and make it easier for us to connect the dots and keep them well.
That's beautiful, Brian.
So Brian, just within that, even, can you just share the difference between, um, a role as a podiatrist? And I know we talked about what's covered, what isn't covered, and then also this foot care nurse that you had mentioned. Can you share a little bit about their roles? And like I had said to you earlier, I never heard of a foot care nurse before. I've
Yeah.
never even recommended a foot care nurse to any of my patients. I've said podiatrist before, but I've never said a foot care nurse. So if you could share a bit more about, who to seek and why you might seek one versus the other, and how that might work, that would be great information.
Awesome. So the easiest is, okay, if somebody needs foot care and we know that they're having foot pain or big issues, they should see a podiatrist. I mean, the podiatrists are the specialists that are trained to recognize all problems and know what to do about them. Now, where a foot care nurse comes in is when somebody needs routine foot care. They need toenails cared for and calluses cared for. Podiatrists do that, but it's not covered in all situations. So insurance doesn't always cover the routine foot care. So they go in the first time, yeah, that's going to be covered by insurance. But it's those repeat visits of trimming someone's toenails that may or may not be covered by insurance. And that's where a foot care nurse comes in. They are usually private pay. So they're using, they can't, just with their license, they can't bill insurance. So it's a private pay situation. But they'll come into the home. They'll make it an amazing experience where the person usually, so they'll do a foot assessment, and then they'll take care of toenails and calluses, basically a minimally invasive procedure, right? There's very low risk. And these nurses usually have at least 30 hours of hands-on training. Plus, if they've become certified as a certified foot care specialist or a certified foot care nurse, they've at least had 30 hours of training to do that and passed an exam that says, yes, they know how to take care of these routine foot problems.
Sure.
Wow.
Does that answer your question?
Yeah. So just share a little bit more about what's covered for regular foot care, because I know that's a big issue.
That's a big question.
I loved how you said earlier in our conversation that, not everyone can touch their toes, right? There's probably a huge population. I would love to know what the statistics are on that. How many people at what age can they touch their toes?
Serious. I don't know that one. I can tell you 50% of people over the age of 70 have toenail fungus. And when you have toenail fungus and you're over 70, it's very challenging to take care of your own toenails because they're thick. The typical toenail clipper that we've been using all our life, all of a sudden it doesn't work anymore, and you need somebody to help you out. But inability to bend, so arthritis, blindness, diabetes, blood thinners are all reasons why somebody else should be taking care of, somebody else should be taking care of those feet, and not the individual themselves. Sometimes family members can do it safely. That's on a case-by-case basis. But if they have underlying disease states, then we need to be careful. And those things are covered with financially. They're covered with a podiatrist if the person has underlying health conditions that put them at risk for an infection or for toe loss or whatever. So like diabetes with vascular disease, diabetes with neuropathy, toenail fungus. Those are the things that are often covered in a podiatrist's office. So if a patient can get there, then yeah, a podiatrist will often take care of it. But we have this other gap. Some podiatrists are saying, hey, I don't want to do foot care at all because it doesn't pay well enough. So Medicare pays about $35 and the podiatrist can't charge a visit. So that's where you get into the financials, but the procedure itself is $35 about for Medicare, which just doesn't pay well enough for all the office staff, for the amount of time that's taken, for the instruments that are being used. And so some podiatrists are saying, you know what, I've had enough of this. Have a foot care nurse do it, or we'll have a medical assistant do the care, and then we'll train them individually so that we can keep taking care of the other things that are more complicated, if you will.
Highly reimbursed. Yeah, it makes sense, Brian. I think that in so many ways you've got to balance everything, between having a business, keeping it running, keeping everybody paid on staff, keeping them I guess, satisfied with their work, right, and their overall careers and what they get to do on a daily basis. And so,
Yeah.
you got to tell me this, Brian, when you guys took your time off, which I think is absolutely beautiful, and I hope that a lot of people have that opportunity to do it, and you went to a foreign country and you saw what was going on in care in that country.
Yeah.
Tell me about one, like, how did it impact your heart, your kids' hearts, on the way that they kind of look at life in general, and how did it inspire what you're doing today and trying to do?
So for my kids, being lost in another culture, because you arrive lost. You can't speak the language. They go to school and they don't understand what's being said in most of the class. So you develop a big degree of empathy. Like, you stop looking down on other people for any reason. And you just say, wow, we're all people and we all have struggles. And so that's one of the beautiful things about taking kids to a foreign country. And then you also become very grateful for what you have, because you're like, oh, wow, we have a smooth road to drive on. That is a very nice luxury in the United States that we take for granted. We complain a lot about that single pothole when, you've been on some roads that are pretty crazy with no freeways, you name it, or the crazy traffic laws and stuff. Anyways, but it gets, you just develop a huge sense of gratitude. And we talked, for our kids. As far as care is concerned, in Argentina, there's not this role of a podiatrist. So there's even a bigger gap. They have a foot care provider is probably a better way to say it. Okay. That delivers care in Argentina, but they can't do surgery. I don't even think they could do ingrown toenail procedures. So they have an even bigger gap of foot care, because your orthopedic surgeons, they often, these are problems that they don't deal with very often sometimes, or it's not what they want to be dealing with. So the role of a podiatrist is very, very important. And I'm really glad that we have that profession in the United States, in Europe, and in Australia, because there's a need for a specialist in just the foot and the ankle, and a broad specialist, not just an orthopedic bone specialist, but a skin, bones, nerve specialist. And that's what a podiatrist does. And then the foot care nurse is filling that secondary role of the routine foot care.
Yeah, I love that, Brian. I think that kind of perspective can bring you back with some fresh ideas and ways to be able to approach some things in society you see. And so one of them that I'm really curious to get your perspective on and for our audience to hear is this: why do we not talk about foot care? Like, why is that something that's almost taboo, Brian, that people are almost thinking, I should be able to do this and I shouldn't have to ask for help? And then it gets to a point where you've got to involve a specialist like yourself to take care of all the things that should have been done previously. Why don't we talk about foot care? And then two, how can we make that a more comfortable thing to be able to, I'm trying to avoid all the puns that I can use here. How do we make that a more comfortable way for us to engage in that conversation?
That's a good question. I think we have a hard time talking about feet for a few reasons. One, they stink and they're ugly, and we don't like to show them off usually, right? I mean, there's that sense like, oh, keep them covered up if there's anything abnormal. And who thinks their feet are cute? There's very few people think like, oh, I have nice looking feet. But so there's this feeling like, oh, feet are gross, right? And we need to take that away a little bit, because every diabetic, when they see their primary care doctor once a year, if they're doing a yearly, the shoes and socks need to come off. And we need to somehow educate people that it's okay for people to look at my feet, even if they're not nice looking, or even if they have toenail fungus, So
yeah, I think that taboo element of being able to look at the feet kind of leads me into my next question is, what can we learn from our feet? Like, we sometimes don't respect things we don't totally understand, or we don't value things we don't really understand entirely. So tell me this, from an expert in that space, not showing our feet, not talking about our feet, what are we missing out on? Like, what are some of the cues that we could have for patients to be able to see, hey, I'm noticing my feet are looking like this. What could that be telling them? What could that tell a clinician that just doesn't have the level of expertise that you do in that space, so we can really value looking at feet more often?
Oh, that's a great question. So their nerves, when you start to get a sensory nerve disease like diabetes or even alcoholism that can cause nerve damage, some of them are hereditary. it happens in stocking and glove distribution, and that's what we learn in our medical training, right? And so the feet are affected first because they have the longest sensory nerve in the body that we're going to notice, right? And so when you start losing sensation in your toes, there's been some damage going on for a while, and we need to do something about it. So that's one thing with the nervous system. It's a huge demonstration, or it's a huge revealer of what's been happening. Vascular, if they have swelling, they have venous insufficiency. If they have poor blood flow, they have peripheral vascular disease and arterial disease, which is often affecting the heart as well. If they're having arterial disease in the feet. So it can tell you a lot about that health as well. And then skin conditions as well, especially swelling. And a lot of that comes back to vascular. If they have poor skin health, it's usually there's poor blood flow and whatnot.
Yeah.
And then toes are interesting too, because there's often imbalances in the tendons that over time they start to get hammer toes and curled toes, bunions, and these deformities that make it more difficult to wear shoes comfortably. And so all of those, you can see a lot in those symptoms and problems. And I guess the toe deformity it doesn't necessarily extrapolate to the rest of the body, but it is something to keep an eye on because they have to be accommodated and sometimes fixed.
That makes perfect sense. I think as being an indicator of disease or another manifestation, and two, precipitating into even worsened conditions, when it comes to gait, mobility, which then leads to other issues with metabolism, et cetera. So I think that's so important. So I hope more people listening, if you guys get anything from this, take your shoes off when you go see a doctor. Like make sure you're saying, hey, can you look at my feet, and then get referred off to, if they are not sure what to do next, to an expert like Brian to be able to take those next steps. And I tried the next steps kind of deal to avoid that. Awesome. Okay, so the other piece that you've mentioned several times that Donna asked in the very beginning was this with a foot care nurse in particular, someone with a specialization to take care of some of these things. When someone is saying, I've got a mom or dad that can't touch their toes, and I did see the stat, it's literally over 50% of people, and more than that with men, that cannot touch their toes in the United States, right? And so does that mean they can't bend or accommodate themselves to be able to do foot care? Probably not. There might be a higher percentage there, but still, it's a pretty massive number, when those can't take care of their toes. So if that's coming to the place that we have caregivers that often listen to the show, Brian, and they're like, well, I've been trying to take care of mom and dad's toes, for a while, and it's just becoming either more difficult, like you said, because of brittleness of individual nails, or them becoming thickened, or I don't know what to do with this individual callus, or whatever the case may be. Other than going to their primary care provider, where are some resources for them to look and some next steps for them to take, like companies like Clipped, for them to go, okay, I could find a company that could really help me do this and be able to take care of mom or dad or grandma or grandpa, whoever it might be, that they don't have a foot problem that comes forward because I'm not able to do what I thought I was able to do as a care provider.
The best resource right now is probably afcna.org. The American Foot Care Nurses Association.
Okay.
They have a list on there, and they're revamping their website. You're going to look at their website, and you're going to be like, wow, that's from the early 2000s, maybe late 90s. But it's getting updated, and they have a list of nurses there that are certified in foot care. If you Google foot care nurse, you may find a few other nurses that aren't certified. I like to stick with the certified because then I know they've had 30 hours of training. And that they've done an exam to say, hey, they know how to take care of nails, because the biggest thing that I see with people that are poorly trained doing foot care, including salons, is not sanitizing instruments well enough to avoid cross-contamination with toenail fungus.
Makes so much sense.
It's unlikely that they're going to cause an open wound and give somebody a staph infection, but it is very likely that if they don't care for their instruments properly, they're going to give somebody else toenail fungus from someone else. So gross, huh? So
shake. So we talked about a little bit at the very, very start of the show, I'm always thinking about the 4 M's and what matters most for the patients: medications, mentation, and then also mobility. And I'm really thinking that our feet, after exploring more about this, is really the foundation, right? And it's the foundation to our bodies, and being able to move. And how does medications affect the way our feet feel, even, or what happens with our feet? Some might cause edema, for example, and cause more issues that way. So I'm just curious, in thinking about these 4 M's, how would you say, like, what should people be doing to keep their feet healthy? I'm assuming that maybe there's some exercises that might be important for, like, you're talking about blood flow, keep the nerves healthy. Are there recommendations that allow for that and that we should be thinking about? And then also, when we're looking and watching our feet, shall we say, I always think that it's important to share with people the importance of using a mirror to look at your feet, especially if you can't see your feet, especially the underside of them, or to look for sores and things like that with neuropathies. So just thinking about that, like the ebb and flow of what people are doing that might be harming their feet, but how can you keep your feet healthy too?
Great question. Some of the biggest things, like we talk about vascular disease, movement. If you keep limbs moving, if you walk every day, you're gonna push blood back to the heart and the venous system. You're gonna avoid diabetes, right? And then avoid having insulin resistance, to where if you don't develop diabetes, you're not likely to develop neuropathy. And so if we can avoid those medications altogether by taking care of the body and exercising and moving, it's going to help a ton with the feet. Also, the arterial disease. So we talk about venous flow and pushing blood back to the heart, getting rid of swelling. But the arterial flow, the blood coming down, using those limbs, again, keeps those legs healthy. So doing the things that your cardiologist recommends can help the feet a lot too, and the primary care doctor. Those are huge parts of it. If they're on blood thinners or something, that can increase the risk of another reason for a nurse versus someone else or a podiatrist to be taking care of routine foot care. One interesting statistic, you talked about mentation and cognition. One interesting statistic is the rate of depression in somebody that has a chronic wound, which is common in our diabetics with neuropathy. And that is a very depressing thing to have. So if we can avoid those types of situations, and wounds lead to antibiotics that cause bowel issues and GI flora upsets. So if we can avoid some of those things by keeping feet healthier, is a huge win for a patient and their longevity and their quality of life.
Yeah, that makes a ton of sense, Brian. Yeah, and I know that we talk often, Donna, with lots of guests about decreased levels of hearing, in particular, and that being an isolating kind of component to life. Well, if you can't walk or move or feel comfortable doing so, also another major isolation component when it comes to increased rates of cognitive decline, Alzheimer's, et cetera, that we've seen in lots of statistical papers out there that becomes problematic. So speaking of not being able to move and get around, Brian, that becomes something that I think your company is really trying to address pretty significantly, with saying, how can we get someone out to you if you can't even make it in to be seen overall?
Yep.
Another piece is a convenience of life, kind of thing. What have you learned so far in kind of this early stage of the company of getting nurses out to see patients as opposed to them coming in the clinic? What are some of the benefits you've seen from directly going into the home?
I think the first thing is they get somebody that's there with them for 35 minutes to an hour. It's not a hurried visit, because we're not dealing with the confines of trying to get insurance and all that stuff and make enough money to make this worth it, right? It's something that they're committed to giving them time and conversation and great care that feels great. And so it's a very pleasing thing. And touch, I think they're finding a lot of things about like human touch. Man, people love their feet getting rubbed. I think 2 or 3 times this week in a caring for people, people have said, wow, it just makes me want to go to sleep. It just makes me just like, oh, melt into my chair when I get my foot rubbed. And it's really pleasant, And so that's why there's nurses that want to do this too, is because people love it. You go and you take care of their toenails and they feel 5 pounds lighter. You give them a foot massage at the end and they're just like happy, a cloud nine. They just love it. And for sure it's decreasing that isolation. It's bringing care. It's improving their human dignity, because ugly feet are embarrassing. People, even though they may not show them to everybody, it's still embarrassing when your toenails are half an inch too long, So it's really a wonderful thing when someone can enter your home and share time and conversation and ask about their life, and they get to share. And then it's really myself, who loves to work with my hands, and I like carpentry and I like surgery, taking down some toenails that haven't been cared for a year is like really fun. And all the mass destruction that's left on the floor afterwards of all the nail clippings. And it's like, wow, look at the work that I did, and the patient feels it too, and they love it.
That's so
Wow.
funny.
That's nice to have that visual of transformation, I guess. I did something. It's interesting you say about touching feet. That can be something that's almost like people are very uncomfortable with their feet being touched. And then also it can be a very therapeutic experience overall. I know that my parents, they went to a church when they're in the Yakima Valley that did washing of feet. And at first they'd never done it before. And they said it was very uncomfortable, like initial experience. And then they realized that everybody has feet and everybody needs their feet to be washed. And they felt like it was a really beautiful, like, exchange between human beings to be able to connect those things together. And I think it's an interesting thing that your team is doing, to be able to have that kind of experience where someone can be vulnerable and can be cared for at the exact same time, which I think is a really beautiful piece. What have the nurses that have worked with you said about this experience on their side of the equation?
Oh, well, I have to be careful, because we don't want to drain the hospitals of their nurses, right? Because we need them there. But I've had several nurses say this has been the most satisfying thing that they've ever done in their career.
Nice.
Wow.
That's wonderful. So why, or is this happening in hospitals? Like, I'm sure people land in the hospital with diabetic foot and with very long toenails and all these other things. So is that care being done bedside in the hospitals? What about long-term care? Is it part of the care for older adults that is kind of locked into that long-term care equation as to who needs to see them?
That's a good question. I'm hopeful that we can get to a point where we can somehow reimburse nurses for this, because right now we can't. And if the nurse is working under a podiatrist, then she can deliver care, but that podiatrist has to be physically present. And I'm hopeful that we can, change some laws in the nation to where that will be an option, or at least paying her even though she's not, the podiatrist isn't there with her, or him. I say her, but her or him. We have male foot care nurses as well. So I'll tell you, in the hospital setting, as a foot and ankle surgeon, when I was on call, I would not accept a call to take care of somebody's toenails in the hospital. And it's kind of sad, but it's just, for me, it's such a common need that I didn't want to be abused in that situation where somebody would have called me in for something that was so simple, but should be cared for on a regular basis as an outpatient. And so it's I kind of feel a little bit embarrassed to even share that, but I wouldn't do it in the hospital. And so we need somebody that will, and these nurses are probably the best option. Now, a hospital can get these nurses trained. So you can still get a nurse trained, and you can just make it part of the hospital protocol that there is a foot care trained nurse that can go and trim toenails. And that's probably what we need to do. We probably need to educate hospital systems to say, hey, you need to have at least 3 or 4 nurses on your staff that are trained to do this, that can go around and take care of these people that come in, especially those that are homeless or have difficulty getting to an appointment, because sometimes they're creating wounds. Literally, they're hitting other toes, curling around, impinging on the skin and creating a wound that's going to land them back in the hospital and have a how many $1,000 stay again, and medications with antibiotics and all that. So let's avoid those things. We need nurses that can care for these problems in the hospital.
Yeah, I think, Donnie, you bring up the hospital. It's an interesting one, especially discharge. We think about all the problems at discharge and transfers that end up happening with us just not doing everything we need to. And foot care seems like a very logical thing that would end up occurring. And education upon foot care. I'm sure a lot of my discharge colleagues will say, like, Kevin, do you know how many things we have to cover upon discharge, and like how do we fit these kinds of things in, which I understand, right, in lots of ways. And the second argument I guess I'd have back to myself is, like, just because we've taken care of it at discharge doesn't mean those toenails will not grow and will not have additional problems that happen. So we have more to take care of. Tell us this, Brian, and if you don't have the stats, and that's perfectly fine, or if you have just some general semblance of things that you see in the hospital, is this. Oftentimes, Don and I, being pharmacists by training, we see like the third leading cause of admission and readmission oftentimes is medication related, adverse drug effects, right? That end up occurring and folks come back in. And so a lot of times, and many of our guests have talked about, why are we not doing prospective reviews of folks' medications to avoid this? It's a massive cost center. And we're starting to see more payers directly say, or insurance, I say companies for our audience here, go, we need this. Like, we need this, and actually saves us money as the payer, and it saves the patient money and time for not going back in for an issue. Mm-hmm. Let's apply that to foot care. What are your thoughts, and what have you seen, Brian, when it comes to if we would just add on more preventative foot care, like what your team is doing, what would we benefit from societally and from a payer perspective with readmissions and other issues that you're seeing as a podiatrist in the hospital?
It's a great question. I would say it would be hard to see how much effect you're having on normal feet that just have long toenails. But if you have a diabetic that is admitted for a diabetic foot problem, which is very high, I can't remember what it is exactly, but I think it's 1 in 4 diabetes related conditions is from a diabetic foot problem or ulcer or infection. And so if we were to follow those, and we were to plug them in and say, hey, you're having a nurse come to your home every 2 months because you've been admitted, and it's 2 months for the rest of their life, right? These problems will not go away. Even if their diabetes becomes controlled, that neuropathy, that nerve damage is done. You can't reverse the nerve damage. At least we haven't figured it out yet, right? So if you were able to follow those and have somebody see them every 2 months, that would save limbs and improve quality of life without a doubt. But it would be great if we could do something like that and connect nurses to that. That would be great. Now, podiatrists oftentimes they'll connect them with their podiatrist, but sometimes they get lost or difficulty getting to an appointment. If you miss one appointment, sometimes they're lost to follow up, or for who knows how long until they see a primary care doctor again that says, hey, you got to see your foot doctor. So I think if we had a nurse, though, that's coming to the home, you can keep them connected better.
Makes so much sense, Brian. And when it comes to, I guess this is an education point Don and I were asking you to tell us about before the show, and I'll ask you one that's just kind of right here. It makes a lot of sense from an ROI, a return on investment standpoint, to go, this makes so much sense to be able to invest in this, send someone out, especially for those individuals that are extremely high risk, to be able to avoid them from coming back and receiving additional care, financially, clinically, et cetera. When it comes to those really complicated individuals, the opportunity to be able to go into the home and be able to take care of the feet and have a specialist like a foot specialist from a nursing perspective, go out and do this, it makes sense. When the nurse is in the home, what ability is there for the podiatry team or the PCP team, whoever it might be, to be able to have a televisit, a live video audio visit with those patients to be able to talk about more complicated aspects of their overall foot care? Is that an opportunity? Is that something that Clipped is looking into or doing already? Tell us more about that when it goes kind of, hey, great, we're taking care of the toenails, or we're taking care of the feet in general. What are some of the next steps for those complex patients?
Oh man. So I was strongly considering this, and we were going to build this into our platform, telehealth and everything. Yeah. But then I dug into the issues with nurse reimbursement and these things. And I basically decided, you know what, it's not worth the cost to build right now. because it doesn't. You have to have direct supervision, and right now the way Medicare sees direct supervision is not telehealth. It is physically present in the same building, able to come in at a moment's notice. And for foot care, you don't need that. You could definitely look at a foot and get the nurse's perspective on the assessment, and you can make good decisions and care for more people and reduce more risk, right? If we had a nurse that was connected with one or more podiatrists doing this. So yes, I think it would be great. And I do hope to include it in the platform at some point. Right now, we've put the brakes on it because of the Medicare or the insurance reimbursement issues that we would have with it, and the cost to build it into the platform. But eventually, I think we will get there. And I hope that we can change some of the way things are managed. And I talked with Kevin a little bit about the basically taking care of a group of patients and showing an improvement in their outcomes. And I think that would be something that could be really beneficial if we could get connected to the right people to see if, hey, does this decrease admission rates to hospital? And it's healthier for longer and potentially save insurance companies money if we can take care of people and avoid problems instead of dealing with the aftermath.
So all the insurance companies currently listing Medicare Advantage, Medicaid, et cetera. If you're hearing this, we need to create a program for Brian and team to be able to test this out within your patient population and see what the ROI is. I think
that's right.
I think.
Yep. What is it? $50,000 for an amputation like visit for a diabetic. If a diabetic loses one toe, they're going to lose others if there's not consistent care. So could we avoid that?
For sure. You had mentioned earlier when we were talking, Brian, that podiatrists and foot and ankle surgeons, you are actually limb salvage experts. And I just want you to touch a little bit more on that and just the impact of what you're doing and how do you save these almost to be amputated types of toes, feet, etc.
Great question. It's through all aspects of the spectrum. And ideally, we're involved before the amputation happens, before the diabetics developing neuropathy. They're educated to have a yearly foot exam. And if we're having those yearly foot exams and they're seeing a primary care doctor and hopefully controlling that A1C, then we can avoid a lot of the problems and be limb salvage experts that way, right? They don't even have to worry about losing a toe because they're taking care of it. And then when they get into that moderate risk category, then we become the ones that connect them to the right shoe gear, the right orthotics, and those things. And then when they become the high risk, where they have developed a diabetic foot ulcer, if they've developed one diabetic foot ulcer, they're going to develop others unless we do something to help avoid them. And the diabetic shoes are helpful, but you often need returning care. And that continues with a podiatrist. I believe that still needs to stay with a podiatrist. It's the people, though, that are the high risk where they are ulcer free, and we can keep them that way for the most part. They still need their toenails taken care of and maybe some mild callus trimming. And that's where a nurse could come in and really help to avoid the readmission. Or, if we were to plug this in differently, this platform is really built for nail care and callus care. But if we were to plug these nurses in and say, hey, you are the prevention specialist for a readmission for a diabetic foot problem, that'd be amazing. I think that would really help to help that limb salvage mentality. Now, then you come to the side of, okay, we already have a severe problem like an infection and this person's admitted at the hospital. Now we become the limb salvage experts because we're trying to prevent a major limb amputation. Because if they go to the wrong specialty, sometimes they'll take off too much too soon. And we don't want that, right? So a good podiatrist in a team of an infectious disease specialist, a vascular surgeon, and a podiatrist, that's your holy trinity in limb salvage.
Wow.
You want those 3 people involved at a good institution, and then you're going to prevent limb loss, or at least lose as little as possible, right?
Sure.
They'll take off a toe instead of below the knee, or they can prevent maybe toe loss entirely. We can't save everything, but we can.
Right.
We can do better. And then it's that team going forward, that vascular surgeon that keeps the blood flow coming to the limb, that's going to prevent amputations on the road, and the podiatrist trimming calluses, getting them into the proper shoe gear, keeping them going forward. The infectious disease specialist, hopefully they're on the sidelines, right, and only stepping in when needed. But the podiatrist and the vascular surgeon are often need to continue to follow that patient over time, perpetually, right?
Mm-hmm.
They don't all have blood flow issues, but I would say 90% of the diabetics that come in have some microvascular disease or something. And I like them to see a vascular surgeon, because 10% of the time they do nothing, but 90% of the time it seems like they're going to do something to improve the blood flow that can help us heal from the infection, or help us heal from hopefully a minor amputation like a toe.
I love that. That's super helpful. And I think the dream team of trying to have the preventative group of what are the lifestyle changes that we can make to those individuals? How can we modify the drug regimen and optimize it? I think there's just so many kind of aspects to care that are really important in saving limbs and preventing those kinds of issues. Let's get really nerdy here, Brian. On your and I's phone calls we've had together, thankfully I can appreciate that with my brother over from the Tri-Cities area.
Yeah.
Let's talk tech. Let's talk, what are you using right now for technology to be able to help out? I know that I've seen applications out there that they have 3D foot scanning, basically for like shoe fit, they're trying to use through your iPhone or other phone, kind of technologies. What kind of things are you kind of seeing come along the way to either help the clinicians that you're sending out to help patients, or 2, you're just looking into to say, this could be part of the future in foot care?
That's a great question. There are some interesting things out there. I'm not as well versed in them. So like socks, there's monitors with socks that you can put like a pressure monitor in a sock or in a shoe and see where that person is having increased pressure and leading to, diabetic foot ulcers and whatnot. They do have 3D foot scans. They have that they're using to make diabetic shoes, and that's becoming way more efficient than the old model, which was casting them with a plaster cast and then removing that and sending it off to a lab. So that it's much quicker, scan the foot, goes directly to the lab. The lab makes the orthotic that goes inside of the diabetic shoe, and we can send them on their way. The technology, what else? There's some cool technology with foot drop and braces and things that are really helping people keep mobile.
Wow.
Even if they develop some of the really nasty diabetic complications related to neuropathy, like Charcot foot. So It's kind of a weird word, but if you have really severe nerve damage, your joints can kind of melt in the right situation, and your foot can become very deformed. And so that we have some really neat bracing options to avoid major reconstructive surgery and some of those modalities. As far as my platform is concerned, we're looking at making the business of foot care nursing simplified, because most of these nurses are on their own, and they weren't really trained in business. Most of them weren't. Some of them maybe. Yeah. But instead of them having to market, do their own website, track their miles, be the scheduler, be the EHR, we're trying to make it so that there's so much in one that we're just making it much, much simpler. And a lot of the nurses that actually went into this space are retired, or kind of after they've worked at the hospital for a while and they're ready to be transitioned to a different phase of life. Then this is a great space for them, because it's very flexible. You get to choose your hours, and then it's very pleasing to the person that you're taking care of, right? Where it's not always that way in all nursing situations, and you don't have to work with those punk surgeons or doctors sometimes that they complain about, but
interest,
right. So anyways, so we're trying to make a platform that's very user friendly and helps them do their business easily, and efficiently.
Makes so much sense. My last one, Donna, for Brian is this one. We're weirdly, I don't even know how it happened, but it is November right now, and so I'm going to ask you a 2026 question here, Brian. Give me two things. One of them in the really excited about, and two, an obstacle to be able to overcome for Clipped in 2026. What are you really excited about doing in this next year? And what's the one obstacle that you're really excited to tackle and get over the top of?
Great question. So what I'm really excited for is we're finishing up our website development to where we'll have a really nice place for people to go, both nurses and patients. And that's going to be live here in the next couple of weeks. And we will see how much of a difference that makes for getting the word out and connecting providers with nurses. So many of these referrals come from providers, home health providers. So when I get a referral for foot care, because I'm actually doing this work as going to homes and taking care of feet. Even though I have my surgical practice, I'm doing this so that I can kind of learn what it's like to be a foot care nurse. Mm-hmm. So in that space, I kind of lost my train of thought. But anyways, we're gonna getting those connections where the nurse with the referrals and the patients, so all three, we need to kind of get the word out there. So connect them all. So I'm really excited about that. I think that's coming and it'll be great. The thing that I'm really excited for to see how it goes and trying to solve the problem is training new nurses.
Amazing.
So they need to have that 30 hours of training. They need to take that exam. They need to have education credits, right? To be able to sit for that exam. So right now there are basically two main ways to get that certification. You go to Everett, Washington for 3 or 4 days, or you go to somewhere in Maine. I think Maine has a program. So you're on the two ends of the United States, but either one it's a lot of time and travel costs and the course cost. So, but they can also get that training hands-on, be a foot care nurse that's already in the area or a podiatrist that's willing to train them. And so now what I'm really excited about, and I'm hopeful that this can really grow, because then I think we can get nurses to enter the field more easily, but still well-trained, is a training program that is local, and finding local proctors that can train nurses. We could pay those nurses enough to where they feel like, hey, this is worth it for me to train somebody else. And then we set up the program so that we make sure that training is robust and quality. And then we can get nurses to enter this field more easily and more readily, so that we can, as you start getting a spot of a nurse here, a nurse there, then this program, this Clip platform is going to help connect the dots with the people that need it and the nurses or providers that can give that care.
That's awesome.
And that's exciting.
It is exciting. It's crazy to think it's not already done.
Yeah, it is. It's interesting. And that's why I'm like, somebody has got to fix this.
Thank you, Brian.
I'm not a tech geek or a developer, but here I am trying to become a tech geek and a developer, and it's been fun. It's been a fun journey. It's taken a lot longer. I've been at this for 2 years now, developing this platform, and it's surprised me how long it's taking. But trying to make a scheduling platform when you're going door to door has been very challenging, and we've solved the problems, but we still have more. And every time we solve one, we seem to uncover something else. So.
I love it.
World of development, my friend. That's too good. Any final questions for Brian?
Yeah, just real quick. We talk about it every episode. What do you want patients to walk away with, and what do you want providers to walk away with today?
Providers, make sure you're having your patients go to the right place for foot care. So your podiatrist is the first line of a defense. And if they just need toenail care and they have no risk factors, then there's likely a foot care nurse in your area. And if there's not, you can contact me and we'll find one for you. So on clipcare.com, you can go to the website and you can email us. And I actually put feelers out, and I try to start recruiting nurses in areas where we need them. So we're going to grow that into the next year. What I want clients to know is don't settle for a pedicurist's office. And if you don't feel comfortable caring for your loved one's feet, there are alternatives. You will have some resources in your area. And it's surprising. A lot of these resources are hidden and they're not well known, but there's likely someone or some place that has someone that has good training taking care of feet. And the last thing I would say is what I want patients and clients or loved ones to know that is make sure that wherever you're taking your loved one for foot care, that they are cleaning their instruments properly. So ideally an autoclave. If not an autoclave, they have to be following the correct protocol to get rid of all the fungus. Otherwise, they're at risk for getting fungus somewhere else. So
amazing. That ending with a public services announcement. I love that too.
Yeah.
Brian, thank you so much for joining us. I've learned a ton, and I can't believe this isn't already happening. So thank you for bringing us this information, and I wish you all the success with your business.
Thank you so much. It's been a pleasure.
Yeah, thank you so much, Brian. Thanks everybody for tuning in. Brian, thanks for the things you're trying to do for society, and one of those kind of issues that just hasn't been answered. And I hope that that's exactly what Clipped is able to do in 2026. And for everybody here listening, we've got a few more episodes left of the Med List for the rest of 2025. We're excited for you to join us, and then we'll take a holiday break and be back. But thank you all for tuning in. Have a wonderful evening, and you can catch us on all your streaming services, LinkedIn, YouTube, Facebook, all those spots. And we'll talk to you next time on the Med List. Bye-bye.
Okay, take care.